Hey, good morning and good afternoon, depending on where you are. Thank you all for joining our webinar today. My name is Bill Glowacki, and I'm the VP of Sales here at Vivid Supply. As a trusted PPE supplier, we appreciate the opportunity to provide you with education and insights regarding evaluating face masks. This is our third educational session in the past 6 weeks. The first was done by Justin Julio on selecting exam gloves. Last week, Taylor Davis did a session on how the Iran conflict affects the supply chain. And today, I'm joined by our face mask product manager, Ayo Alade, who will be doing a majority of today's session. Ayo, would you introduce yourself?
Of course. Thanks, Bill. Hi, everyone. My name is Ayo Alade, and I'm excited to have the opportunity to provide education and insights regarding evaluating facial protection for your health system.
Thanks, Ayo. So in a few minutes, I will walk through why facial protection matters, understanding performance standards, how to choose the right mask, the current marketplace, and implementing a mask strategy. Vivid Supply is the biggest PPE provider you've never heard of. We provide 1 in 10 masks used in North American hospitals. That's over 200 million masks per year. Backed by 30 plus years of high quality self-manufacturing, we focus exclusively on what we do best: gloves, gowns, and masks. We forge strong partnerships to provide cost savings, supply assurance, and clinical reliability. We'll have time for questions at the end of the webinar, so feel free to add your questions to the Q&A box on the right-hand side of your screen. If you run into any technical difficulties, please leave a message in the chat, and a member of our team will be glad to assist you. And with that, I'll turn it over to the superstar Ayo to take it from here.
You're too kind, Bill. Thank you. So, good afternoon, everyone, and thank you for taking time to join today's session. Let's start with the foundation: why facial protection continues to be a non-negotiable part of healthcare safety. Masks in healthcare aren't just about COVID. They serve various distinct protective functions, such as blocking respiratory droplets, protecting against blood and fluid splashes, preventing cross-contamination between patients and staff. What makes healthcare setting particularly high risk is the combination of close patient contact and the fact that staff are wearing the mask throughout their shift and are also exposed to biological fluid. Proper mask selection has a direct downstream impact on staff safety, patient safety, and your system's ability to stay operationally resilient. Now, within the broad category of face masks, we're going to talk about 2 types used in the hospital settings. I have not included the N95 in this presentation simply because it represents a small volume of usage within the healthcare setting. So first, procedural masks. It has an air loop attachment. It's designed for routine patient care. It's also easy to don and doff, and it's the most commonly used in healthcare settings. Second, we have surgical masks. They have the tie attachments, predominantly used in the ORs, and it offers a more adjustable fit simply because of the ties. Each of these masks serve a specific clinical purpose, and mixing them up or defaulting to one style across your entire health system is where we sometimes see procurement decisions go sideways. So, masks are rarely used alone. Depending on the exposure risks, particularly in high splash environments like trauma bays or oral surgery, they're typically combined with some form of eye protection, such as face shield or eyewear. Face shields protect the eyes and mucous membrane from splash exposure, while eyewear or goggles are more form-fitting, so they're typically used when there's a sustained risk of fluid contact. The point here is that mask selection happens within a broader PPE strategy, and whoever is managing that strategy needs to be thinking about the full protection picture and not just masks in isolation. The chart on the screen tells a really interesting story about how the market has shifted with regards to air loop and surgical tie usage. In 2019, prior to COVID, the air loop mask made up roughly about 67% of the US hospital mask market, while surgical ties sat around 32%. By 2022, driven by pandemic era procurement patterns, air loops had jumped to 92%. What this suggests is that a significant portion of air loop masks began being used in settings like the operating room, where tie masks are traditionally preferred. We have seen some rebalancing since then, with surgical masks recovering slightly to about 12% from 7% in 2025. Now, what's driving that recovery is a combination of, first, surgical program volumes returning to normal levels post-pandemic, and second, clinicians reaffirming the value of better fitting tie style masks in operating room environments. From a best practice perspective, a surgical tie mask is typically the more appropriate choice for the OR, given the importance of secure fit and consistent protection. So now that we have the clinical context, let's get into the standard piece, because that's where a lot of confusion in the market lives. In North America, medical masks are evaluated against ASTM F2100. This is a standard published by ASTM International, which is a body recognized by the FDA for this purpose. The standard tests 5 things. First, bacteria filtration efficiency, also known as BFE. This tests how well a mask filters out bacteria-sized particles. Next is particle filtration efficiency, also known as PFE, and this measures a filter's ability to filter out submicron particles. We also have fluid resistance, which measures a mask's ability to block synthetic blood penetration. And then there's also differential pressure, also known as delta P, which measures the breathability by testing airflow resistance across the whole mask construct. This basically tests how easy it is to breathe through a mask. And last, flammability. This measures a mask's ability to ignite or burn when exposed to a heat source, spark, or flame. Also worth noting is that as of July 2025, the FDA now only accepts the FDA now only accepts ASTM F2100-23. This change includes PFE results test updated to F3502 method from F2299. We have created a page where you can find all the details about this change, and we will share the link to the page alongside the webinar recording. Understanding ASTM tests and the level categorizations help healthcare systems match mask performance to clinical risk. The table on the screen is the clinical translation of the metrics that we discussed on the last slide. ASTM level 1 is your baseline. This is appropriate for low fluid exposure environments like outpatient clinics or area of low risk of splash. At least ASTM level 2 or better, ASTM level 3 are masks you want to have when there's meaningful splash risks, such as in the operating room, in the labor and delivery wards, during emergency procedures, etc. On the next slide, we'll take a look at how masks have historically been positioned in the marketplace. Now, the chart on the screen focuses on air loop masks, and this shows how ASTM level mix have shifted in the air loop segment from 2020 through early 2025. Now, when you look at this chart, a few things stand out. Level 1 masks have been consistently dominant, hovering around 55% share. But more importantly, we see a meaningful growth in level 3 uptake, which has nearly doubled from around 12% in 2020 to over 22% in recent quarters. During the pandemic, people demanded rated products, shrinking unrated mask demand in the market. The unrated category has also shrunk dramatically from nearly 45% of the market in mid-2020 to under 12% today. This is a sign of market maturation. Buyers are demanding certified products, and the flood of unrated pandemic-era masks is working its way out of the supply chain. So if you're still buying a significant share of unrated masks, you are the shrinking minority, and you're taking on a compliance risk, because the FDA's framework requires that masks used as PPE by healthcare personnel either hold a 510(k) clearance for surgical grade or at minimum meet the labeling and performance requirements for Class 1 medical masks, medical devices. So a mask that simply says 3-ply or quotes a filtration rate without the ASTM certification or FDA registration does not meet that bar. So now that you understand the standards, let's talk about how to actually apply this to your purchasing decision. Mask selection should always be clinically driven. This requires a clear understanding of ASTM standards to ensure masks are appropriately matched to hospital settings. Consider the type of procedure. Does it require a tight-fitting mask for adequate protection? Evaluate the level of fluid exposure risk, such as in oral procedures where there's a higher likelihood of splashing in the operating rooms or during labor and delivery. It's also important to factor in how long your staff will be wearing the mask. Are clinicians having brief patient interactions and changing masks frequently, or are they involved in longer procedures where the same masks are worn for an extended period? Finally, staff feedback is essential. Are clinicians comfortable wearing the masks? Now, here's the thing nobody talks about in procurement meetings, but every clinician knows that a mask only works if it is worn correctly. And masks that are uncomfortable are far less likely to be worn properly. To support consistent compliance across your facility, there are 5 key factors to evaluate. First is breathability. If wearing a mask feels like breathing through a pillow, resistance and non-compliance are inevitable. Clinicians need protection, but that should not compromise airflow. Second, skin compatibility. So watch out for irritations or allergic reactions. If masks are causing hives or discomfort, staff will naturally avoid prolonged use or adjust them frequently. Third is air loop comfort. Poorly designed air loops or really tight air loops can lead to air fatigue and pain over time, especially during long shifts. Then we have fogging with eyewear. Masks that cause glasses or shields to fog can interfere with visibility, safety, particularly in clinical settings where precision matters. And last, we hear a lot of this is odor and material quality. So unpleasant smells from manufacturing, packaging, or storage can create an immediate negative experience and reduce acceptance. When masks are uncomfortable or feel hard to breathe in, clinicians tend to adjust their masks constantly, pulling them below their nose or leaving them under their chin, which defeats the whole purpose. So, what are some of the key questions to ask when evaluating a new mask supplier or product? There are 6 questions worth asking before anything else. First is the mask clinically validated? Has the product been tested in real clinical settings like a trial? Clinical validation helps confirm that the masks perform as expected during actual patient care. Where eyewear compliance is necessary, but you find a lot of inconsistencies, is a mask with an integrated face shield like a visor a more effective option? If staff aren't consistently wearing goggles or face shields, a mask with a built-in eye protection can improve overall compliance and reduce exposure risk. Does the mask meet FDA and ASTM requirements? Ensure that masks meet recognized performance standards like the ASTM level for fluid resistance and filtration. That confirms a baseline level of protection. Is regulatory or third-party test data available? Independent verification adds credibility. So look out for documented test results that support claims around filtration efficiency, breathability, and fluid resistance. Does the manufacturer have a reliable track record? A supplier history matters. Consistent delivery, quality assurance, and responsiveness during shortages are all critical in healthcare settings. And lastly, is the product quality manufacturing consistent? So even though an approved mask can vary between batches, reliable manufacturing processes ensure that each shipment perform the same way, reducing risk for clinicians. Answering these questions early on filter out a lot of risks. So the pandemic exposed a hard lesson that most healthcare systems learned the difficult way. If you only have one supplier, even if it's a domestic one, you are just as vulnerable as if you only have one wheel on a car. A single source supply chain, regardless of where that source is located, creates a single point of failure. Onshore only isn't automatically safer than offshore only. What matters is diversification. Other important factors to consider are, does the manufacturer have a quality system like ISO 13485 set up? Do they have lot traceability? So can they manage a recall or quality event? Is there inventory reliability? That is, can they actually scale up during a surge or when there's a scarcity of products? We here at Vivid Supply strongly encourage healthcare systems to think seriously about strategic stockpiling. The standard of care pre-2020 was just-in-time inventory for PPE, and that model does not hold up in a disruption. Even a 60 to 90-day buffer of your highest moving volume can be the difference between continuity of care and scrambling for products at inflated prices. Now, let's zoom out and look at what's happening in the mask market right now, because the environment has changed significantly since 2020, and it directly affects your procurement strategy. So 3 things are currently shaping the current market. First is post-pandemic new entrants. The 2020 demand surge drew in hundreds of manufacturers with no prior medical mask experience. The result was a race to the bottom on price and quality, especially on the air loop styles. And unusually low prices could be a signal of compromised quality, inconsistent filtration, poor lot-to-lot consistency, or certifications that don't hold up under scrutiny. Second is geographical and tariff pressures. Tariff on Chinese origin PPEs have continuously shifted manufacturing to Southeast Asia and Mexico, complicating country of origin documentation. And then third is innovation. The good news is that legitimate manufacturers have used this period to advance. For example, in melt-blown filtration, we have melt-blown filtration improvements, which allows for higher BFE and fluid resistance without sacrificing breathability. Air loop and nose wire ergonomics have evolved significantly, improving comfort in the process. In summary, manufacturers can produce more protective masks without necessarily sacrificing comfort. Let's talk a bit about the US domestic manufacturing. There has been a lot of policy interest in domestic masks manufacturing since the pandemic, and some real investments behind it as well. But the honest picture is that domestic manufacturing alone remains a small fraction of total supply. It also carries a meaningful cost premium. The structural reasons are straightforward. Labor and factory efficiency costs are not closable through efficiency gains alone. Most importantly, a lot of the core raw materials such as melt-blown filters, non-woven polymers are still being imported. That complicates the country of origin documentation. So a made in a US mask that has foreign sourced critical components isn't necessarily a disqualifier, but buyers should require component level documentation before accepting domestic origin claim at face value to avoid source washing. So let's bring it all together and talk about implementation. How do you actually build a mask selection framework that works in practice? The most effective strategies we've seen in healthcare systems share one thing. They're not made by procurement alone. The best outcomes come from a cross-functional team. Practically, that means starting with infection prevention to define risk tiers by department or procedure type, getting clinical feedback from the users who wear this mask for hours at a stretch, verifying ASTM compliance with actual test documentation, vetting your manufacturer, and then running a cost per unit analysis that accounts for total usage and not just unit price. Okay, so yeah, I'm gonna pass it on to Bill now for any questions that we might have.
Hey, Io, thanks. Really nice job. Appreciate your effort there. We do have a few questions that came in. So looks like we have a few minutes here. I'll rifle them at you if that's okay. Put you on the spot a little bit, right? Yeah.
Go for it.
Okay. All right. So how do we balance cost with performance when the specs look so similar on paper?
That's a really good question. The short answer is specs on data sheets will only tell you the floor and not the ceiling. So you can pick up two masks and they have the same ASTM level. They both show BFE of 98%, and they can still perform very differently in clinical use because the standards test the material and not the finished mask on the face. The variables that don't show up on the spec sheet are lot-to-lot consistency, breathability over a full shift, skin compatibility, air loop durability, and things like that. So a mask from supplier with a weak quality system may pass certification on the first batch and then drift on the 10th. The practical approach is to request third-party test reports and not just a single certification document. You can also pair that with a clinical pilot in 2 or 3 departments before committing to a contract. Staff will always surface comfort and compliance issues in 2 weeks that a spec sheet will never reveal. The final point that was made in the question was price. And price per unit is not the same as the cost of protection. A mask that your staff constantly adjusts or replaces mid-shift because it has a broken air loop has a hidden cost that doesn't show up in the purchase order.
Great, thank you. You mentioned that ASTM standards have been updated. Can you shed some more light on that?
Yeah, of course. That's a question that we're hearing a lot of, and it's a really important one. The ASTM standards for medical masks have transitioned from F2100-21 to F2100-23. And that change took effect in July 2025 in the US. The primary change affects the particle filtration efficiency testing, also known as PFE, and specifically the method that is used to measure it. So under the old standard, that's F2100-21, PFE was measured using the F2299 latex sphere method, which allowed flexibility in test parameters. That means that results could vary meaningfully between test labs. Like this test the same mask and you get different results across different labs. But the new F2100-23 standard replaced the F2299 with F3502 test method. And this uses a fixed particle size of 0.3 micron. And that size is considered the most penetrating particle size. And also the test method also uses a fixed flow rate, really similar to how you test an N95 mask. The result of this is you have more reproducible results and consistent results across all labs. Here's the most important thing for your clinical team, for your clinical team to know is, even though the PFE numbers look lower, that is ASTM level 1 now reflects 80%, level 2 and 3 now show 85%. That test in itself reflects a more rigorous test method and not a reduction in the mass actual performance. So think of switching from a lenient exam to a harder one. A score of 80% on a harder exam may represent a better real world performance than 95% on an easier one.
Excellent. 80%. I don't think I ever got that. Thank you for that. How about one more question?
Yeah, of course.
How do we expect, we love our geopolitical right now. So how do we expect the current geopolitical landscape to impact mass in the coming months? And is there anything we can do about it proactively?
Yeah, this is such a timely question under the current geopolitical landscape. The honest answer is the situation is fluid, but the direction is clear. The cost of raw materials are going up and the lead times are becoming less predictable. So what can you do proactively? Three things. First, lock in pricing where your contract allows. Many GPO contracts have price escalation clauses that might not necessarily have been triggered yet. So it's probably a good time to do that now. Second, diversify your mass portfolio rather than relying on a single manufacturer. Supply chain experts are actually now recommending that healthcare systems diversify suppliers and have backups in place rather than the traditional strategy of consolidating into a single vendor to drive savings. And third, review your stockpile positions. As I mentioned earlier, a 60, 90-day buffer on your highest volume SKU has moved from best practice to baseline risk management given the current environment. At Vivid Supply, we're also monitoring the situation really closely, and we have created a page on our website for updates, and we'll share the link alongside the webinar recording and other links with you.
Hey, Io, thanks for taking the time to organize your thoughts and share your vast knowledge with us. I think it was great.
Yeah, of course.
And for those of you on the call, thank you for joining us today. If you do have a question, please reach out to your Vivid Supply rep, and we'd be glad to get back to you with answers or provide additional clarification on something that Io talked about today. Our team is certainly glad to do that. You'll also see shortly in your inbox an invitation for another webinar on gowns and apparel, which is scheduled for June 3rd. So that would be our fourth in a very short period of time to deliver continuing education to the marketplace. So thanks for joining us and hope you have a great rest of your day.